TopMedTalk.
Hello and welcome to TopMedTalk Down Under. I'm Kate Leslie and I'm here with my co-host Andy Cumpstey at the annual scientific meeting of the Australian and New Zealand College of Anaesthetists and Faculty of Pain Medicine. And we're here in Cairns, which is in far north Queensland in Australia. And this must be the fifth or sixth podcast that we've made so far.
I'm the rest, I think, Kate. We've been doing really well. We've been busy every break, but it's great because there's such a buzz around the place that it doesn't really feel that tiring. You just keep going and doing more and more. And we've got these amazing speakers that keep coming to chat to us about all the brilliant things they've been talking about. And we've been really lucky with all our plenary speakers coming to visit as well. I mean, it's been such a good meeting with every plenary speaker being fantastic, but from all over the world. There's been a great Canadian contingent here this year as well. And we've been speaking to the Canadians on our podcasts, and we've got interviews with the British speakers as well. What's been your highlight so far?
Oh, so many highlights. I love the breaking trials session. I talked about that in the last podcast. We had some great sub-studies from some of our large randomised controlled trials.
Yeah, really exciting data.
But given who our guest is, I should say that his plenary talk and also oration at last night's college ceremony were really fantastic. So without further ado, we'd like to welcome Kevin Fong. Kevin is an anaesthetist, a retrieval medicine specialist, a broadcaster, a wannabe astronaut, and a previous astrophysicist. He has been on the podcast before, so he's our friend. And we'd like to welcome you back, Kevin. You've had a pretty busy visit so far.
Yeah, it has been busy, but it's been fun. It's lovely to be here.
What are your current roles, Kevin?
So I have quite a complicated job plan. So about a third of my time is clinical medicine still. So just anaesthesia in trauma and emergency theatres, and then a couple of days a month on one of the regional air ambulances. It's not really retrieval; it's sort of pre-hospital primary response stuff with air ambulance charity Kent, Surrey, Sussex, which I really enjoy. It's my favourite part of my clinical work, I think, and then I've got an academic role at University College London. I'm professor of innovation and engagement in a department called the Department of Science, Technology, Engineering and Public Policy. So that's broadly it. And I've just taken on a new role as Chief Medical Officer for something called UCL Partners, which is an innovation hub in London. So it is busy at the moment, but it's good. It's fun.
What do you do in your spare time?
Yeah, not a lot. So I mean, it's interesting because I don't actually have any conventional hobbies, but the things that feel like hobbies to me, I'm lucky enough to occasionally, call them work as well. So some of the broadcasting stuff is, that I feel, it feels quite creative to me, and it feels, at times like I guess the closest thing to a hobby I have.
And you did go running this morning.
Yeah, that might have been a mistake, but yeah.
Well, your plenary talk was entitled Risky Business. That was a fascinating talk. Can you summarise it for our listeners?
Well, it's just really this thing that I've been thinking about for about the last decade, which is that, we talk a lot about patient safety and we talk a lot about risk in healthcare, but I'm not entirely sure that we've got that model correct, and partly because we rightly, as conscientious professionals, are worried about the things that we get wrong. We're worried about the harm we cause through the errors in healthcare. And it's right that we should be so, and you absolutely need to have infinite curiosity about events that lead to harm or death amongst patients. But I'm not sure that we ever approach it in the way that I think is appropriate for the healthcare system as it is today. We're very linear. We very much sort of hark back to the days when, there was a single individual who was responsible for most of the variance in the care. Because the way we deliver healthcare today is in these sort of sprawling, vast systems where it's very, very difficult to identify what it was that fundamentally went wrong. You can identify contributing factors, but very rarely can you identify someone smoking gun, some root cause. And so I think part of that plenary was about how actually we need to sort of reframe our understanding of what healthcare is in the context of, this big, complex system with technical parts and humans in the loop of it. And from that stems a bunch of consequences, which is, that when things go wrong, you need to investigate it, but with that lens and looking at, there's this very multidimensional set of circumstances that have led to a system failure that has let a patient down. And I think if we take that approach, then we're likely to do more good for our patients in the future, and it's a more honest approach to it. So I think the old-fashioned narrative of pursuing people as individuals or root causes for accidents, it probably doesn't help us, actually.
You came out with a lot of fantastic quotes, but there's one quote that it really struck a chord with me in the plenary. I wrote it down, but you said, "Anaesthesia is the management of risk in a complex system that's already in a state of failure." And then went on to talk about how we often downplay what we do. And it's interesting just hearing as we open this podcast now, again, you're downplaying all these amazing roles, you have all these amazing things you've done today, they've done this morning. That's in our nature, isn't it? It's what we do. But how do we rise above that? Because you're absolutely right.
Well, I think we do. So we, as a community of anaesthetists, we all have that chat between us, and we acknowledge between us, and it's an unspoken thing that we know the complexities of what we do and fundamentally what this thing is. And it is exactly as that quote suggests. We are manipulating complex systems, and very often we're catching them in a state of failure and trying to rescue them back from where they are. And it's an extraordinarily difficult thing to do. And we joke with each other that it's not that hard, but I don't think we do ourselves any favors by doing that. And the problem is that projecting outside this community, other people take that at face value at times, and think that our job is simpler than it is. And so, I think that we should be honest about how difficult it is and actually, what it is that we do. It's really interesting. I've thought about this a lot. We all talk about the Dunning-Kruger curve, don't we? About how, the novices are unconsciously incompetent. They don't know what they don't know. But actually, that's the left side of that curve. There is a right side, I think, whereby you've spent enough time and you've learned enough through hard experience that you've forgotten how hard it was to get there, and you suddenly think that it's all easy, and it's easy for you. But I don't think it's the acquisition of those skills has taken years, if not decades. And so I think that there is another side to the Dunning-Kruger curve, I think.
There's a bit of a theme running through our podcast at this meeting about personalised medicine and how, you can do a randomised trial and show that a pain medicine drug doesn't work, but you can drill down and find out that it works in a subset of the population. And I think, I was thinking the same thing applies to what you said about how hard it is. It is actually easy for a properly trained but, not deeply experienced person to anaesthetise some people for some procedures. That is undoubtedly the truth. And then there are patients at the other end where it's hard for anybody to anaesthetise them, and there's a continuum in the middle. And we need, I think, to have mechanisms to better identify people who need differently qualified or experienced practitioners looking after them.
Yeah, and it is, as we know, it's hard to identify people who are going to be quote unquote straightforward to anaesthetise, right? We think we're good at that, but we get surprised every now and again. And in the same way, part of the role is being able to deal with the emergent problem. That then emergence is a property of a complex system, and so that is. For us, it's a vigilance task, right? And then knowing how to respond when things arise unexpectedly. And, all of that, I think, is the skill. I mean, there's a reason why we have a postgraduate training of many years, and that's why we're a medical specialty. So,
and again, you touched on it very nicely in the plenary talk, but alongside that is this risk of moral trauma, or when things do go wrong, we blame ourselves, it's our fault. And you talk very nicely about it being the system at fault a lot of the time.
But yeah, it's interesting that because rightly, we have searched for progress in patient safety and how can we do less harm through sins of commission, omission, etc. But what that has led to inadvertently is a sort of fairly permanent focus on, all the stuff that goes wrong, and we forget the great good that we do. In the UK, you always get read the statistics on the number of people who are harmed or the number of people, who are where things don't go well. But there are 600 million patient consultations per year in the NHS, and the vast, vast, vast overwhelming majority go without problem. And in many of those encounters, people are left much better off and improved. But we sort of take that as a given. But actually, if we don't celebrate that, when we have to look into the sort of the dark corners of what's happened elsewhere, there's nothing to offset it. And so part of the plenary was about sort of trying to recast the role of the human in these loops and see them not as a point of fracture and frailty and the reason that things go wrong. And that has been, again, inadvertently the narrative, I think, of the last quarter century, which is humans are fallible, they make mistakes, and if only they tried a bit harder, less people would die. But what humans are in these systems is overwhelmingly they are the reason that stuff continues to work at all. They are, your principal asset. They make things, they adapt and they make things work when they don't want to work. And all of us who work in any hospital with any resource stress at all knows that at 7:45, nothing can really happen because there isn't a bit of kit or there isn't a bed or there's not quite enough staff or whatever. But everything happens anyway because people find ways to make it work. And so we should recast ourselves, or at least give ourselves credit for being that asset, as people, being that asset in the system. So yes, there are times when we get it wrong and we make mistakes and the system fails because of it. But most of the time, actually, we get it right and people are improved, or their quality of lives are improved because of it.
I think the pandemic revealed that most of what went on in hospitals in the pandemic went really well.
Yeah,
the people worked hard and they put their heart and soul into caring for these desperately ill people and worried members of staff and their families. And there was a lot of credit given to that in Australia, at least by politicians, but the focus was more on how many people died and were we giving them the right drugs? And you famously have spoken about that publicly.
Yeah, well, I think COVID was a very sobering experience, particularly in the United Kingdom, and I think it is the greatest challenge I think the National Health Service has faced in the history of its existence. On paper, when you looked at what the increase in demand for healthcare that was created by COVID, we shouldn't have been able to cope. We should have just run aground. But we did manage somehow to keep moving. And again, that is absolutely testament to the efforts of a frontline workforce and the people who helped lead them, who were able to pivot and face a threat for which the service was never designed, and on the eve of COVID was under-equipped and under-resourced and understaffed to face. But the reason that we closed the gap on that one at great cost was because of the people in the moment adapting to the threat and solving the problems as they fell to them. And the great success of COVID was allowing people to make decisions as close to the point of consequence as possible.
And how do you think that experience has changed the NHS or your ideas about how workforce should be organised?
So I think that if you're managing a healthcare system, it's easy to... There's always a bit of a gap, isn't there, between the supply of the supply of resource to meet the demand for healthcare. And almost always that gap is breached by the human workforce smearing themselves into that gap. That's how we run, just from day to day. And in COVID, that gap got enormous, and the workforce did also then throw themselves into that gap to cover it. But the problem is that that stretch comes at a cost, and we know that because we've objectively measured what happens to the mental health of the staff who are exposed to the greatest operational loads during COVID. And the problem is that we often make the assumption that stretch can happen without any cost. And, it shouldn't need saying, should it, that healthcare systems have a finite capacity and healthcare workers have a finite resilience. But we kind of tend to operate our systems as though that is not true, that there is infinite capacity, and indeed, in other evidence given in the UK COVID inquiry, it was the point was made that, and I think by the chief scientific or deputy chief scientific advisor at the time, Angela McLean, that they had spent too much time thinking about the equipment and the beds and not enough time thinking about the people who would have to deliver the care. And I think that's the general operating principle for healthcare systems even outside of a pandemic.
I agree, but I think it's always really easy to look back and say, in hindsight, we did this. How do we take that forwards for whatever comes next? What's the next challenge, which we can't see yet, but there'll be some future challenge, hopefully nowhere near as bad as COVID. But how do we learn from that and move positively forwards from it?
Well, I think you should ideally deal with COVID the way that we would deal with any clinical case that had not gone according to plan, which is you have to take the team, or just any, not even that it didn't go according to plan, but with any case that is a difficult case, which is you take your team offline and you have a very robust and but honest discussion about what went well and what went badly, not in the interests of apportioning blame, but of trying to learn so that we're better in the future. Now, it's much more difficult to do that with COVID because of all the political entanglements, but we still need to do it, nevertheless. That's the only way we protect ourselves from the future. And you say you're hopefully not as bad. There's no suggestion that we may not run into something that would be at least as bad. And there are elements of COVID actually that feel actually lucky in a way. And for example, that it wasn't a pandemic in which there was a large in which children were greatly affected. Not all pandemics leave children unspared, and indeed it was a pandemic in which largely it was the oldest and the frailest who are most at risk. But again, we've seen pandemics in the past where younger people who've got a different immune response to the virus are the most vulnerable. So I don't think it's a given that this is going to be the worst thing we're going to see for another 100 years by any chalk. In fact, I think quite the reverse. I think all the evidence points to the idea that these events are going to be more frequent in the future, and that this is something that we need to learn from so that we are better able to face it when it next comes.
I'm quite optimistic about certain aspects of that. One is things like vaccine production and antibiotics. I think we learned a lot from the last pandemic about how to do that quickly. And if the intentions of billionaire philanthropists come to fruition, there should be better systems in place. I mean, even last time they produced vaccines in record time. The second is the widespread use now of platform trials to rapidly get through drug discovery and therapeutic options. So I think those two things are positives about that. But I think if there's another pandemic in our clinical lifetime or memory, that's going to be really hard on us mentally.
Yeah, but it's all about the choices you make long before the pandemic arrives. And there's a couple of other things to say, which is, yes, the vaccine was an example of something that went really well, as were our platform trials. And that is achievement that we should celebrate. But I've spoken to vaccinologists, and they say, it is not a given that the next pandemic we encounter will be able to, just because we did it within a year this time, it does not mean we'll do it within a year next time. They said there were amazing organizational shifts that they made, and that included manufacturing large volumes of vaccine at risk before they really knew it was going to work, knowing that actually if the trials found out discovered that this was not a very good or usable vaccine, all of that was going to go in the bin at cost. That's mostly how we accelerated the production of these things. But also, while we have better mechanisms for getting the vaccines in place, you can't say, well, we know in the future all we have to do is to hold the line for 6 to 8 months and then we'll have vaccines. That may not be true. Now, we may get a vaccine faster, but we may not get one as effective or within the same time frame. So what we know about pandemics is they're all like fingerprints. They're all unique in character. And we need to draw the best general lessons we can from our experience of COVID-19 so that we give people a chance next time around, a better chance next time around.
When you were talking about how we should respond, you talked about local group debriefing. Are there any mechanisms for national debriefing or professional group debriefing that soothing and nurturing and cleansing activities that we can do on a larger scale?
So it depends on what you mean there. If you're talking about how we recover the workforce, the problem is that when we talk about well-being and healthcare, it's seen as so synonymous with pots of muesli and yoga mats, and that is not by any means what that means. But what well-being to a healthcare workforce really means is actually creating working environments and patterns of working that are sustainable, that do not lead you to have problems, as we right now do actually across many of our healthcare systems, whether it's in high or low and middle income countries, whereby we have poor retention, high sickness rates, high burnout rates. And there's a real question here about whether we've configured these environments correctly. There are a number of things I think that we get wrong fundamentally in healthcare that we're really only beginning to wake up to. And I think COVID was useful in unmasking some properties of the systems that are otherwise hidden. And one is this, that when you're in a resource-constrained environment and you look in front of you and you have the needs of a patient and the needs of the perceived needs of the staff, you always choose the patient because that is what we're trained to do, patient-centered care. But actually, that model, which trips off the tongue for us so easily and seen as such, it's seen as as an unlimited virtue, but it isn't. What that is actually an unsustainable working model. And you create this false dichotomy between the two, patient and staff, when actually the needs of the patient are aligned with the needs of the staff. And if you're able to invest in the welfare of the staff, you will be also at the same time investing in the better care of the patients. And until we make that cognitive shift at organizational, strategic and leadership level and political level, I'm not sure we'll get to the right answers.
Andy, my co-host, and I are in different generations of medicine, and I was brought up in the heroic model. The long hours, the stay late, that there's a patient, we have to treat them.
I think Kate's just saying I don't work hard enough in a jokey sort of way. But I think, but you're right though. But generations change, perceptions change, cultures change. But we're sitting here in an amazing place under a banner that says future-proof. There's been a running theme all the way through our pods at this meeting about sustainability. And I think you're right, Kevin. The things you talk about going forward, we somehow need to make a sustainable future-proof plan for our workforce that's going to last whatever the next challenge is. Yeah, but
I just want to come back on Kate's point there, which is, so there probably was a different social contract in both directions, and I was sort of, even when I started work, I was at the tail end of that, where it was more a vocation than a professional traineeship. Exactly. And we were still doing, in my house here, I did do weeks that were 100 and more than 100 hours long sometimes. But there's a few things. One is that that's not the only thing that changed. So the attitudes of the workforce may have changed, probably did change. The attitudes of the public towards that workforce also changed. And so that social compact has changed. There's a greater expectation from the public of that workforce, rightly or wrongly, and then the work itself has definitely become more intense. Things that were routinely fatal are now marginally survivable, and there's an expectation that survival will often come. And the thing that I always say now to my residents is, and I feel so old for saying it, but when I was a house officer and a patient came in with a big hemiplegic stroke, there was so little that we could do. And so you document the neurology, and that was the end of your work for the night, because it wasn't even worth scanning them that night, because there was no acute intervention usually, really. And anyway, there was no availability of a scanner usually. So that was the end of it. Now you're on a clock for scanning them to make sure that there isn't some heroic clot retrieval that can happen in that time, etc., etc. And that's just one example of how much more resource is invested, how much effort is invested in all these patients. And so the job has changed, and expectations have changed, and what we can do, we can do so much now, which is great, but that also modifies the way that through-coming healthcare professionals have to work. And we have to ask ourselves whether then the models of care, the models of workforce that we have are fit for purpose going into the future. Because yes, you're right, as all of these things, it's a complex picture. The way that the workforce understands themselves, the way that the public understand the healthcare workforce, the way that the work has changed, has all shifted. And you can't get in a time machine and go back 20 years and hope that it's all like that again. You have to face what's facing you in the future. So there's no good saying, well, in my day, and denigrating a through-coming generation. It is what we have now for lots of different reasons, and we have to deal with it. And that means maybe we need to recalibrate our understanding of what the shape of a medical career is.
Well, on that note, we'd like to thank you for your generosity of coming on the podcast in your incredibly busy timetable. And we hope that you have a lovely time for the rest of your time in Cairns.
Oh, yeah. Well, thanks for having me. It's been great being here again.
Thank you so much. So that's it for this podcast. You'll be able to find it on our app and on our website, and also on social media. We're on Facebook, X. We're now on Blue Sky. We're very modern. And we're also on YouTube. And if you go to YouTube, please give us a big thumbs up and subscribe, because every little bit helps. Finally, we'd like to thank our sponsors, BD, GE and Solventum, without whom we could not bring TopMedTalk free and open access to the world. So thanks, Andy. Thanks, Kevin.
Thanks, Kevin.
Thank you.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.